Hello everyone and welcome to our module on toxicology. Let's start by talking about carbon monoxide. Carbon monoxide is an odorless, colorless gas, and exposure is toxic to humans. There are many ways that people become exposed. They can be exposed through smoke from fires. Carbon monoxide can get into heating systems. It can also be produced by motor vehicles. The reason carbon monoxide is toxic is because it binds to iron and heme at 240 times the affinity of oxygen. It binds much more powerfully than oxygen, and it forms a structure called carboxyhemoglobin. This is bad for two reasons. The first reason is that the carbon monoxide blocks oxygen binding sites, so less oxygen can be absorbed. Basically, it causes a functional anemia because even though the number of red cells and the amount of hemoglobin is normal, there's less ability of red cells and hemoglobin to carry oxygen. The second thing it does is modify the structure of hemoglobin so that even sites that have bound oxygen cannot offload that oxygen. Carbon monoxide is an allosteric modifier of hemoglobin, meaning it shifts the conformation of hemoglobin so it's harder for oxygen to be released. This is referred to as shifting the dissociation curve of oxygen to the left. I'll show you what that looks like in a minute. But so both of these effects, the fact that less oxygen can be absorbed and the fact that less oxygen can be released, are responsible for the toxicity of carbon monoxide. Shown on the slide is an oxygen dissociation curve for hemoglobin. The blue line is a normal curve. The dotted line is what happens when 50% of the sites on hemoglobin are bound by carbon monoxide. There's a fall in carrying capacity, so hemoglobin can no longer become fully saturated up to 100%, no matter how high you make the partial pressure of oxygen. In addition, there's a left shift, and this means that at any given partial pressure of oxygen, less oxygen is released and more is bound to hemoglobin. The symptoms of carbon monoxide are nonspecific and not easy to recognize. Headache is the most common symptom. Patients can also complain of malaise, nausea, or dizziness. A classic but rare sign is the presence of cherry red lips. This occurs because carboxyhemoglobin is red. So in patients with carbon monoxide poisoning, the lips become bright red or cherry red. And this is in contrast to other problems related to hemoglobin where the lips become blue from cyanosis. You don't see that in carbon monoxide poisoning, even though there is a problem getting oxygen to tissues. If you use a standard pulse oximeter on a patient with carbon monoxide poisoning, it will usually be normal, and that's because a standard pulse oximeter cannot differentiate between carboxyhemoglobin and oxyhemoglobin. So it will often read normal even though there is low oxyhemoglobin. To make the diagnosis, you need to measure a carboxyhemoglobin level. This is done through a technique called co-oximetry from an arterial blood gas. It's a specialized wavelength analysis of blood, and it will determine the carboxyhemoglobin level separate from the oxyhemoglobin level. Normal is less than 3%, greater than 15% suggests poisoning, and then this is super high yield for your boards, but patients who smoke often have a chronic carboxyhemoglobin level in the 10 to 15% range. This does not mean they have carbon monoxide poisoning. This is a consequence of their smoking. Don't get fooled by that in a board question. And the treatment is to administer 100% oxygen, which will eventually displace the carbon monoxide from hemoglobin over time. Moving on, let's talk about methemoglobinemia. So normally the iron that is found in hemoglobin is in the reduced state, which is the Fe2 plus state. And in the normal human body, there's just a small amount of Fe3 plus iron. When hemoglobin has Fe3 plus iron, it's called methemoglobin, and this form of iron cannot bind oxygen. But because the amount of methemoglobin normally in the body is very small, this doesn't have any consequence. But if something happens and there's excess methemoglobin, meaning there's more of this Fe3 plus iron around, then the patient can develop hypoxia because this iron cannot bind oxygen normally. So methemoglobinemia is usually acquired from exposure to drugs. There are certain drugs which are oxidizers, and they can convert that 2 plus iron found in hemoglobin into 3 plus iron and create an excessively high amount of methemoglobin. Some of the classic drugs to do this are, first of all, local anesthetics like benzocaine. So if a patient has their throat sprayed with benzocaine before having an endoscopy procedure, that can cause methemoglobinemia. It can also happen from nitric oxide, which is an inhaled pulmonary vasodilator. It's sometimes administered to babies who have persistent pulmonary hypertension, and they can develop methemoglobinemia. And then lastly, dapsone is a rarely used antibiotic for tuberculosis, and it also can cause methemoglobinemia. And the treatment, once you identify methemoglobinemia, which we'll talk about in the next slide, is to administer methylene blue. Methylene blue is a reducing agent, and it converts 3 plus iron back into 2 plus iron. So methemoglobinemia in actual practice is easy to miss. First of all, you have to recognize patients who have been exposed to one of those drugs in the last slide and know that they are at risk. When a patient who has been exposed to one of those drugs develops dyspnea, that's the first clue. The second clue is that the dyspnea won't improve with oxygen. If you place oxygen on the patient but they still feel short of breath, that's a tip-off they could have methemoglobinemia, because oxygen doesn't help when you have a lot of that 3+ iron around. When you draw blood from a patient with methemoglobinemia, the classic finding is chocolate brown blood. This is a picture of what it looks like on the screen here compared to normal blood on the left. And this change in coloration happens because of the presence of methemoglobin in the blood. If you do standard pulse oximetry in a patient with methemoglobinemia, the pulse oximeter is going to be unable to detect the hemoglobin. So when there's a high level of methemoglobin in the blood, it will usually show an oxygen saturation somewhere around 85%. Sometimes it can even be in the lower range of normal, but it'll be kind of fixed at this level and it won't change when you give the patient oxygen. The way to make the diagnosis is to do co-oximetry, just like we talked about for carbon monoxide. Co-oximetry can measure a methemoglobin level and tell you how high it is, and if it's increased above normal, that makes the diagnosis. So moving on, let's talk about cyanide poisoning. So cyanide is an inhibitor of the electron transport chain, and when you inhibit the electron transport chain, aerobic metabolism cannot occur. Therefore, anaerobic metabolism will occur, and that produces lactic acid, and that leads to a lactic acidosis. So the classic finding in a patient with cyanide poisoning is an unexplained lactic acidosis with a very low bicarbonate level and a high lactate level. Another potential finding is bright red venous blood. This happens because there's lots of oxygen in the venous blood. So normally arterial blood is bright red because there's lots of oxygen, and venous blood is dark because there's very little oxygen. But in a patient with cyanide poisoning, oxygen is not being consumed because aerobic metabolism cannot occur. Therefore, the venous blood begins to look just like arterial blood with lots of oxygen in it. Other clinical features are nonspecific. They're related to the effects of cyanide on the brain and the lactic acidosis. These are things like confusion, coma, and seizures, respiratory depression, arrhythmias, bradycardia, and hypotension, and ultimately death can occur from cyanide poisoning. So how do patients in the modern era become exposed to cyanide? Well, one way is if they're administered the drug nitroprusside, which is used in hypertensive emergencies, and I talk about this drug in videos in the cardiology section. Shown on the screen is the structure of nitroprusside, and it has 5 cyanide molecules. So if you give a patient a prolonged infusion, they can develop toxic levels of cyanide. Now in actual practice, we don't let this happen because we never administer nitroprusside for more than a few hours or a day. But if you were to administer it for a prolonged period of time, a patient could develop cyanide poisoning. Beyond nitroprusside, there are industrial applications of cyanide, so patients can have industrial exposures. And certain types of plastics, if they're burned in a fire, can produce cyanide. So if a patient comes in very sick after a fire, don't just presume it's carbon monoxide poisoning, especially in a board question. Always remember that it could be cyanide poisoning. There are a couple of options for the treatment of cyanide poisoning. The first one is to use hydroxycobalamin. Hydroxycobalamin is a precursor of vitamin B12, and it contains cobalt. That's why it's called cobalamin. And cobalt can bind intracellular cyanide and form a compound called cyanocobalamin, which is excreted in the urine. So by administering this drug, you promote the excretion of cyanide in the urine. Another option is to use sodium thiosulfate. Sodium thiosulfate donates a sulfur atom to an enzyme called rhodinase, and when it does this, rhodinase will transform cyanide into thiocyanate, and thiocyanate can be excreted in the kidneys. So just like hydroxycobalamin, sodium thiosulfate promotes the excretion of cyanide in the urine. And then the last option, which is used less commonly, is to administer nitrites in the form of amyl nitrite. Nitrates convert Fe2+ iron into Fe3+ iron, and that forms methemoglobin, as we've already talked about. And the Fe3+ in methemoglobin binds cyanide, and this protects the mitochondria. So basically the idea here is to actually cause methemoglobinemia to a mild degree so that that soaks up the cyanide and protects the mitochondria so that aerobic metabolism can occur again. And this can help the patient to recover while the cyanide washes out of the body. Next, let's talk about organophosphate poisoning, and we'll talk about exactly what organophosphates are in a minute. But when patients are poisoned by these substances, they develop what's known as a cholinergic toxidrome. Cholinergic, as you may know, means related to acetylcholine and cholinergic receptors, and a toxidrome is signs or symptoms of poisoning or an overdose. So in a cholinergic toxidrome, a patient has evidence of excessive activity of acetylcholine at cholinergic receptors. And there are also anticholinergic toxidromes, which can be caused by substances and drugs that block cholinergic receptors. So the classic cause of a cholinergic toxidrome and total body excess activity at cholinergic receptors is from organophosphates. Organophosphates are compounds that have a chemical structure like what I've shown on the screen here. They have both phosphorus and oxygen atoms in them connected to carbon groups. And you can find organophosphates in pesticides and also in nerve gas. Patients are exposed by contacting organophosphates either through the skin or by ingesting them or by inhalation. And the way organophosphates cause a cholinergic toxidrome is by inhibiting the enzyme acetylcholinesterase. So at cholinergic receptors, either muscarinic or nicotinic receptors, acetylcholine is released and it's broken down by the enzyme acetylcholinesterase into choline and acetate. What organophosphates do is inhibit this enzyme, and that's going to lead to excessive levels of acetylcholine throughout the body. What organophosphates do is basically amplify the parasympathetic nervous system. The clinical effects that you see are all from overactivity of the parasympathetic nervous system. So remember, that system is called the rest and digest system. So what are some of the things that the parasympathetic nervous system does? Well, it increases GI motility, and so you will see this in organophosphate poisoning. Patients develop nausea, vomiting, cramps, and diarrhea. The parasympathetic nervous system also activates many of our secretory glands, so patients with organophosphate poisoning can have sweating and salivation and also lacrimation. In the bladder, parasympathetic nerves cause bladder contraction and urination, so when patients are poisoned with organophosphates, the detrusor muscle, which is the smooth muscle of the bladder, will contract and this will lead to urination. So putting this all together, patients poisoned by organophosphates will come in with diarrhea, they'll be drooling, and they'll also have incontinence. The parasympathetic system also has effects in the heart and lungs, and so you will see those in patients with organophosphate poisoning. In the heart, the parasympathetic nervous system decreases contractility and slows the heart rate, and so bradycardia is a classic finding in a patient with organophosphate poisoning. In the lungs, the parasympathetic nervous system causes bronchoconstriction, so wheezing, dyspnea, or flares of asthma or COPD are all classic findings in a patient with organophosphate poisoning. And the main way that patients die from organophosphate poisoning, for example, patients exposed to nerve gas, is through respiratory distress and respiratory failure because of these effects shown here. So putting this all together, a patient with organophosphate poisoning is going to present with bradycardia and wheezing and evidence of respiratory distress. Some other clinical effects you can see in a cholinergic toxidrome: the parasympathetic nervous system constricts the pupils, so on eye exam, patients with organophosphate poisoning can have pinpoint pupils. In fact, the pupils can get so small that the patient can be unable to see, and this is one thing that used to happen to soldiers in World War I when they were exposed to nerve gas, is they became blinded temporarily because of the pupillary constriction. Organophosphate poisoning also leads to more acetylcholine activity at nicotinic receptors on muscles, so this can lead to muscle twitching. And then there are many cholinergic receptors found within the brain, so activity at these receptors can lead to things like confusion, lethargy, or seizures. So one way to remember the clinical features of a cholinergic toxidrome is by the mnemonic dumbbells. The letters in dumbbells all stand for the clinical features here, which are all part of a cholinergic toxidrome from organophosphate poisoning. So here's the classic case to know for your boards. A 44-year-old farmer. Remember, farmers use pesticides which can contain organophosphate. The farmer presents to the ER with difficulty breathing. He has wheezing, diarrhea, and unintentional loss of urine. He appears confused. That's from the CNS effects. On exam, he has pinpoint pupils. He's sweaty, drooling, and his eyes are watery, and his pulse is 30. This is a classic description of a cholinergic toxidrome. Let's talk about the treatment of organophosphate poisoning. As I said earlier, the major cause of death is respiratory distress and respiratory failure. This can occur because of bronchoconstriction. There are also excessive secretions which can find their way into the lungs, and then patients can have neuromuscular weakness as well. So because of the respiratory effects of organophosphates, intubation is often required. Patients often need to be placed on a mechanical ventilator until the organophosphates wash out of their system. One thing that's super high yield to know about this is you want to avoid succinylcholine when intubating a patient with organophosphate poisoning. Succinylcholine is a paralytic that's often used for rapid sequence intubation. The idea is to paralyze the patient so that you can more easily pass the breathing tube into the trachea. But succinylcholine has a structure very similar to acetylcholine, and it is metabolized by the same enzyme as acetylcholine, acetylcholinesterase. So if you use succinylcholine in a patient with organophosphate poisoning, the paralytic effects will be significantly prolonged because acetylcholinesterase is inhibited, and therefore you generally try to avoid acetylcholine when intubating patients with organophosphate poisoning. Besides intubating patients for respiratory distress, there are two drugs that can be used for the treatment of organophosphate poisoning. The first drug is atropine. Atropine is a muscarinic antagonist, and so it will block activity at muscarinic receptors, especially in the lungs, and this will improve bronchoconstriction and respiratory distress. Importantly, it has no effect on nicotinic acetylcholine receptors like you find in muscles, so it won't do anything to improve the neuromuscular symptoms, but it will help with the respiratory distress. The second drug you can use is called pralidoxime. This is a drug that reactivates acetylcholinesterase, and so by turning the enzyme back on, metabolism of acetylcholine will start to occur and symptoms can improve at both muscarinic and nicotinic receptors. One super high yield thing to know about pralidoxime though is that when you give it, it initially temporarily inactivates acetylcholinesterase, which makes symptoms worse. This is a brief phenomena that occurs as pralidoxime binds to the enzyme. So you have to give it together with atropine so that atropine will block those muscarinic receptors while the enzyme transiently becomes even less active. Once that period's over, the enzyme becomes more active and symptoms will generally begin to improve at all receptor subtypes. We'll finish this video by talking about Tylenol overdose. Tylenol is a pain reliever and it goes by a couple of different names. Its non-trade name is acetaminophen, but it can also be called paracetamol, and it's often written in clinical charts by the abbreviation APAP, which is an abbreviation of its chemical name, which is N-acetyl para-aminophenol. And the maximum recommended dose of Tylenol is no more than 4 grams per 24 hours. Patients who take more than this amount can develop an overdose syndrome, which presents as acute liver failure. And the liver failure of Tylenol overdose has some unique characteristics. First of all, the onset is very rapid. It occurs within hours of taking an excessive dose of Tylenol. In addition, Tylenol overdose is famous as one of the few things that can cause extremely high AST and ALT. The levels can get into the 10,000s in patients with Tylenol overdose. There are really only two things that can give you liver function test abnormalities into this range. One of them is Tylenol overdose and the other is shock liver. So if you see a patient who's not in shock and the AST and ALT are this high, one of the first things that should come to mind is Tylenol overdose. And in fact, Tylenol overdose patients are sometimes unconscious or not otherwise able to tell you that they took too much Tylenol, so you should suspect a Tylenol overdose in any patient with the sudden onset of liver failure, extremely high AST and ALT levels, and no evidence of shock. Tylenol, which as I said is also called paracetamol, is metabolized into 3 metabolites, and one of them, NAPQI, is toxic to the liver. NAPQI stands for N-acetyl P-benzoquinonamine, and this is the substance that destroys the liver in patients who take too much Tylenol. The reason it's safe to take up to 4 grams in 24 hours is because you have glutathione in your liver cells that can metabolize the NAPQI. But if patients take more than 4 grams in 24 hours, there's not enough glutathione to metabolize the NAPQI, and that leads to liver toxicity. Tylenol takes 4 hours to be fully absorbed and reach peak plasma concentration. So if a patient presents within 4 hours after an overdose, you can administer activated charcoal to prevent absorption. The benefit of activated charcoal is greater the sooner it's administered after ingestion. So if you give it in the first hour after ingestion of Tylenol, the benefit is much greater than if you give it in the third hour, and after 4 hours there is no benefit any longer. Beyond activated charcoal, the antidote for Tylenol toxicity is a substance called N-acetylcysteine. It's the treatment of choice, and it will replenish the glutathione that is lost as Tylenol is metabolized. N-acetylcysteine can be metabolized into glutathione and give more glutathione to the liver to protect the liver against Tylenol-induced damage. And in fact, the survival from a Tylenol overdose is close to 100% if N-acetylcysteine is given within 8 hours of ingestion. Most patients who die of Tylenol overdose present beyond 8 hours, and therefore they can't get N-acetylcysteine in that first 8-hour window. Sometimes patients present and they're unsure of how much Tylenol they took, and so it's not clear whether or not they are at risk for hepatotoxicity and need treatment with N-acetylcysteine. In that situation, you can use something called a Rumack-Matthew nomogram, or RM nomogram, to help you determine the risk of hepatotoxicity. This nomogram is used in patients who have had a single dose exposure to Tylenol. An RM nomogram is shown on the screen. Along the x-axis, you have the hours post-ingestion. On the y-axis, you have the plasma acetaminophen concentration. So the way you use the nomogram is you draw an acetaminophen level, you find the hours post-ingestion on the x-axis, and you plot the patient's value on this chart. If they fall below this black treatment line here, in this range down here, then the patient is at low risk for hepatotoxicity and doesn't need treatment with N-acetylcysteine. If they're above the black line and up in this gray range up here, then they should be treated with N-acetylcysteine. So the major indications for N-acetylcysteine are any patient who is above the treatment line in an RM nomogram, any patient with a level greater than 10 who has an unknown ingestion time. Sometimes patients can't tell you exactly when they took the Tylenol, and in those patients any level over 10 should be treated with N-acetylcysteine. And then lastly, any patient who has ingested Tylenol and has evidence of liver injury, meaning elevated AST and ALT, all of those patients should also receive N-acetylcysteine. Just a couple of quick words on some other treatments. There's no role for dialysis in managing acetaminophen overdose. Acetaminophen is cleared by dialysis, but because N-acetylcysteine is such an effective antidote, dialysis is always unnecessary. And then lastly, cathartics are rarely ever used in the treatment of Tylenol overdose. Cathartics are laxatives, substances like mag citrate, mag sulfate, or sorbitol. They speed up the GI transit time, but they don't alter absorption, and they aren't effective in the treatment of acetaminophen overdose. And that concludes our module on toxicology.